Welcome to our live training on monitoring in labor. Today we are going to jump into the 3 different kinds of monitoring and go over what the evidence has to say. So let's get started. So there are 3 different forms of monitoring during labor. There's continuous monitoring, there's intermittent monitoring, and then there's a mixed monitoring where we're doing continuous monitoring on occasion. So continuous monitoring is a way to increase your risk for C-section without improving outcomes for babies. So why is that the standard in most hospitals across the state? Let's start by talking about the history. So monitoring in labor continuously was created in the 60s. And it was released before any randomized controlled trials came out to show or illustrate that it was a safe choice for families. But there was this idea that we can have way more convenience in the hospital. If we're monitoring people continuously with the belts, we can sit back, the nurses can sit back, watch people be monitored throughout labor and monitor multiple patients at a time. So it was really convenient for hospitals. At the same time, hospitals realized that this supports their liability. If they have a continuous tracing of what's going on with the baby's heart rate, if they were to get sued, they can use that to support liability. So because the baby's heart rate is open to interpretation, this opened up 2 changes in obstetrics. With the rise of continuous monitoring, we have found that more families are getting surgery. So surgery has increased. At the same time, defensive medicine has increased. So this is the outcome of continuous monitoring. So let's talk a little bit more about what continuous monitoring is and what it looks like. Continuous monitoring occurs when you go in labor and they take 2 straps and wrap them around your belly. There's typically a pink strap and a blue strap and 2 little hockey puck circles that go on your belly. This is ultrasound technology that's used to listen to your baby's heart rate all throughout labor continuously without stopping. There are wireless forms of continuous monitoring and there are wired forms of continuous monitoring. So if you can imagine with that little hockey puck, there's one at the top of your belly. That one is listening to your contractions. Then there's another little one that goes on the bottom part of your belly where the baby's heart is, where their chest is, if your baby is head down, maybe in a different spot if the baby is breech. And that is listening to the baby's heart rate continuously all throughout labor. Your baby's heart rate goes through normal variability throughout labor from 110 to 160. That is the normal range for baby's heart rate. And so when baby's heart rate is going through that normal variability, what they can see in the tracing, which is what they're seeing, this line on a graph basically that's illustrating what baby's heart rate is doing, this opens up the possibility for these shades of gray to happen. This basically means that the baby's heart rate, let's say, goes down a little bit during a contraction. This can be normal. It's normal for you to have a contraction and the baby's heart rate to change. Sometimes baby's heart rate goes up, sometimes baby's heart rate can go down depending on what stage of labor you're in. So let's say baby's heart rate goes down a little bit with a contraction, still within the range of normal, and then returns back to their baseline. Let's say your baby's baseline is like 130, for example, and they can kind of stay around 130, then they go down a little bit closer to 120 and then back up to 130. Some providers might see that and go, oh, yep, that's normal. The thing is, another provider may see that and say, maybe that's not normal, because sometimes baby's heart rate could go down a little further than it normally does. Or baby's heart rate can take a little longer to come back to baseline than it normally does. Is that a problem? Or is that baby okay? Because there are so many variations in that normal variability of the baby's heart rate, this opens up the possibility for something that is fine to be interpreted as not fine. And because obstetrics is the highest sued profession, so you have 18 years to sue an obstetrician, obstetricians are sued the most, and obstetricians carry a lot of weight of liability on their shoulders. So if they were to see baby's heart rate doing something that maybe doesn't look super reassuring, are they going to decide to stick with it, keep supporting the person in labor, or are they going to jump to a C-section? They're going to jump to a C-section because they want to protect their liability. That is what continuous monitoring has created in our culture and how it has shaped modern medicine today. So let's talk a little bit more about the risks and benefits of continuous monitoring in general, and then I'll go into more specifics around wireless, wired, internal, external, things like that. So first would be the benefit to continuous monitoring. Maybe I'll say there's two benefits, but this is the only benefit in terms of like health outcomes for mothers and babies, is that it reduces the instance of rare neonatal seizures, roughly 1 in 650 births with external continuous monitoring versus 1 in 325 births with intermittent monitoring. Though the long-term impacts of neonatal seizure are not known. So we don't have research on how a newborn seizure impacts their long-term health, but it does not reduce the risk for anything else. NICU admissions, low APGAR scores, cerebral palsy, brain damage, all of those things. It does not prevent any of those conditions or any of those outcomes at all. We only see a very slight decrease in the risk for newborn seizure with continuous monitoring. So that is the only benefit for baby. The other benefit is that it gives you a continuous visual record and it creates a permanent paper trail, which hospitals and providers will use and rely on for any kind of legal thing. I will say this actually isn't a benefit though. It can be considered a benefit to some people, but it encourages hospitals to practice defensive medicine rather than practice more supportive, ongoing support medicine, right? Where we're taking an individualized approach and supporting parents going through their birth experience. We're kind of focusing on the monitor, focusing on what it's doing, considering liability, and not giving parents the options around monitoring and increasing the cesarean risk for parents just to protect our liability, which isn't cool, right? That's not okay. So other risks to continuous monitoring would be the increase of the probability of a C-section. So choosing continuous monitoring will increase the risk for cesarean by about 63%. And it also increases the risk for forceps or vacuum by about 15%. So the risk for these interventions, which are very significant interventions for the mother, right? Cesarean is like a big deal. It's a hard journey to recover from and does impact the health of your future babies. And at the same time, forceps and vacuum can increase the risk for brain damage to baby, can increase the risk for tearing, can be helpful. All of these can be helpful life-saving tools when needed. But continuous monitoring increases the likelihood for these tools without improving outcomes. That's the piece that I really want to land with you. There's a high false alarm rate. So ACOG indicates that over 99% of abnormal tracings indicating potential cerebral palsy or a potential problem are actually false positives. 99% of the tracings that we see that we think maybe something is wrong are false positives, which means many parents are experiencing trauma, are experiencing a lot of fear and stress and overwhelm, and more forceps and vacuum unnecessarily due to continuous monitoring. There's also restricted mobility. So if you have the continuous monitors that are wired, which means you have the straps around your belly, then there are wires connecting those straps to machines near the bed. You can't go very far. You have to stay in the bed or around the bed. That can impact mobility. Also, if you want to move around, you have wires you have to kind of move around, especially more, there are more if you also have an IV in the IV tube and things like that. There are just like more things we have to navigate, and that makes mobility a little bit more challenging. It also increases stress and perceived pain. So machines beeping, visual displays, and constant room interruptions can distract mothers and can increase stress. So I want to talk about this one a little bit more. Many people say that, well, I want to do continuous monitoring because I don't want them having to come in for intermittent monitoring every once in a while to listen to my belly. I think that's going to be really distracting. Here's the thing though, with continuous monitoring, we're monitoring a baby that is moving through your body. So the baby does not stay still. They rotate, they descend, and they move down. Every time your baby moves away from that monitor, we lost the baby's heart rate. That might be a little bit of a stressful experience, not knowing where the baby's heart rate is. People might come into the room and need to fix it again and again and again and again. Many healthcare workers that I have spoken with, many women giving birth that I have supported throughout my many years, 15 years in this career, I've heard the same story again and again and again, that with continuous monitoring, it's almost like we have to come in more often. The mom is interrupted more often than with intermittent monitoring because we're constantly needing to fix the belt. It can feel very challenging when you're in the middle of labor. So going through these contractions, feeling the pressure, baby's head coming down, going through this really intense experience where we need to relax and focus, having people constantly going, sorry, mama, I got to fix the belt. Sorry, mama, I got to fix the belt, right? And messing with your belly, messing with your belly. Can you get in this position? Can you get in this position? Disruptions, disruptions, disruptions. Frequent disruptions can make it harder to have a vaginal natural birth. That is what you're wanting. Let's talk next a little bit more about the wireless options. So there are wireless options for continuous monitoring, but here's the thing to be aware of. A lot of families say, oh, they offer wireless monitoring. That's great. That's like so high end. I'm going to be able to move around. And that is true. With wireless monitoring, you're not connected to a machine. You can go to the bathroom. You can walk around the room. You can walk the halls. You can do whatever you need to do. And that's awesome. The only downside is that, well, there are two downsides. One, we still have to have someone come in and fix the monitor frequently, probably. The other downside is that your risk for cesarean and forceps and vacuum is still increased by the same amount. So just because you have continuous wireless monitoring doesn't mean that you have avoided those risks. Those risks are still present. The only risk you don't have to deal with is the restriction of movement that comes from the wired monitors. There are also wireless monitors that are waterproof. And the waterproof monitors are a great option if you're wanting to labor in the tub and if you're wanting to get in the shower, because unfortunately with normal wireless monitors that aren't waterproof, we can't access hydrotherapy in labor. So the continuous wireless monitors that are waterproof are probably your best bet if you're wanting to access water and if you're wanting to be able to move freely all throughout labor and access all the mobility that you need to. With those, your risk for C-section and forceps and vacuum are still increased. And some moms complain of a reaction with their skin with that adhesive that stays to their belly. Their belly gets itchy or uncomfortable. You may not have this reaction. If you do, it may happen during labor and really bother you, or it might happen after you have your baby and you might not notice at all during labor. So these are just some risks to be aware of. Next, let's talk about internal continuous monitoring. Still comes with the same risks of increasing the risk for cesarean, forceps, and vacuum, but they do have a few other risks. So continuous internal monitoring uses two different devices. One device is called fetal electrode. And a fetal electrode is basically like a little coil. It's a little copper coil. It's very small and it's connected to a wire. And then it is placed on the baby's head and spiraled just into their scalp underneath the skin. This sounds really scary, but it's just underneath the skin. It doesn't go deep. The only thing to be aware of though with the electrode is that it does come with some risks for baby. It can cause a risk for infection. It can cause a hematoma or bleeding or a little scrape. It will heal over time. It can also be painful. So it can subject babies to unnecessary pain, while they're going through the birth experience. The other tool that is used is an intrauterine pressure catheter. An intrauterine pressure catheter, or IUPC, is basically a tube that is inserted into the uterus and placed there so it stays there. The only thing that the intrauterine pressure catheter can do that an external continuous monitor cannot do is measure the strength of your contractions. A continuous external monitor can monitor when you're having contractions. The intrauterine pressure catheter can monitor the strength of your contractions. Is that helpful though? Is that helpful information to have? Most of the time, probably not. Maybe on a case-by-case basis, I could see potentially it could be helpful, but this is just like my opinion. In the midwifery model of care, when I was a student, when we would suspect that a mom's contractions were not very strong, we would feel her belly. And we would notice the shape of her belly be different. We would notice her sounds change. We would check in with her intuition, and we would consider that more personalized approach. Whereas the obstetric model tends to rely heavily on data and look for data to make decisions and to help identify kind of what's going on. So if we're concerned that contractions aren't strong anymore, should we use an intrauterine pressure catheter and increase all the risks that come with that? Or do we simply just feel the mom's belly? Ask to the doula how the mom's sounds have changed. Ask the mom what she feels is going on, right? And consider that. But that is something that the obstetric model of care does not typically, it's an approach the obstetric model does not typically take. So that's one thing just to consider. With internal continuous monitoring, there's also an increased risk for infection because we have to put something inside and the water bag has to be broken. If the water bag is already broken, then it's already broken. If the water bag is not broken, then we increase the likelihood for risks that can potentially appear by breaking the water. So that suddenly those risks become part of the procedure. So there are the risks to breaking the water, then there are the risks to continuous internal monitoring. The benefit to internal monitoring is that we can listen to the baby's heart rate continuously without someone having to come in and adjust the monitors. So if you're tired of people coming in and adjusting the monitors and you want it to just stay there, internal monitoring may be a good option. This also might be helpful for someone who doesn't really mind the tubes and the extra wires. Maybe they're planning an epidural, so they're planning to stay in bed anyway, and they don't like the feeling of the straps around their belly. Maybe that's really bothering them. I will say that one thing I wanted to add, it is common, unfortunately, for larger bodied people to be told that they need internal monitoring. Sometimes larger bodied people are told that they need internal monitoring and they don't have the choice to decline. That is not true. You can absolutely be monitored externally if you are a larger bodied person, and you have the right to choose if you want any kind of monitoring, a continuous, external, internal, intermittent. You have the right to choose that if you are a larger bodied person or any kind of person. Just because you're larger body does not mean that your right to make choices goes away. So that is a bias, unfortunately, and a myth that larger body people have to be monitored internally. That's just not true. And so just know that you can advocate if you're not wanting that. And we're going to talk about advocacy tools at the end of this training around monitoring. Next, let's go on to the other option for monitoring, option number 2. And this is called intermittent monitoring or intermittent auscultation. It's also known as hands-on listening. This is the form of monitoring that I learned as a student midwife. And this is the form of monitoring that midwives out of hospital, at a birth center, at a home birth, this is the way that they will monitor moms all throughout labor. Intermittent monitoring looks like this. Depending on the provider and other circumstances, monitoring happens between 15 to 30 minutes. So every 15 to 30 minutes, someone will come and monitor your baby and listen to their heart rate. Typically, this is done at the end of a contraction, and potentially on occasion, the provider will listen throughout a full contraction. So for example, in the out-of-hospital model that I learned as a student midwife, we would listen every 30 minutes at the end of a contraction. So we would get the monitor ready. We would use a Doppler, which is that little handheld device that you maybe have been exposed to listen to baby's heart rate at prenatal appointments. We would go to the mom, wherever the mom was. Is she in the tub in a reclining position? Is she in hands and knees on the bed? Is she standing, leaning over the counter? It doesn't matter. We can find the baby's heart rate most of the time without asking the mom to move. Every once in a while, if mom is lying on her side and she's lying on the side where baby's chest is, we might ask her to just move her hips a little bit so we can access it. But very rarely would I ever have to ask a mom to change what they're doing. And I've personally been monitored with intermittent monitoring in all 3 of my births and found that I very rarely needed to ever adjust my position for someone to do the monitoring. I barely noticed it most of the time. So we would go in and to find the mom wherever she is. And we would wait till the mom had a contraction. So she has a contraction, she's moaning, swaying, and we would tell the mom before the contraction that we're planning to listen. And the mom would usually just shake her head, okay. And then when the contraction starts to get to be around 45 seconds, so nearing the end of the contraction, we would take the monitor, the Doppler, and put it on her belly and find the baby's heart rate. And then we would listen to the baby's heart rate, listening for how the baby's heart rate was at the end of the contraction and how it recovers back to baseline. This is an important part of intermittent auscultation. It's not just checking in to see what the heart rate is at any given time. It's listening to the baby's heart rate at the end of a contraction to see how the baby's heart rate is impacted by that contraction and how the baby's heart rate recovers after the contraction. So when we're doing this, we're able to identify if the baby's doing well. If the baby in an out-of-hospital scenario, speaking from my experience as a student midwife, is not doing so well, maybe they're taking like a little longer to come back up to baseline or dipped a little lower, something like that, then we would start to explore options and have a conversation with the mom around how we can support the baby's heart rate in improving. Often, just getting in hands and knees helps the heart rate improve, because if the problem is that there's a bit of a cord compression, if the cord is getting compressed in the pelvis a little bit as the baby's descending, getting in hands and knees often can resolve that. But also, sometimes mom just needs to move around a little bit. She needs to drink more water. She needs to refuel, support herself. And sometimes that can also help the baby. So this is just an example of what intermittent monitoring looks like. The research we have on intermittent monitoring is that it decreases your risk for cesarean, and it does not impact newborn outcomes. So intermittent monitoring is a safe and evidence-supported choice for low-risk moms that decreases the likelihood for a cesarean without negatively impacting outcomes for babies. The only outcome to be aware of is that slight increase in the risk for newborn seizure. It also enhances continuous support. So with intermittent monitoring, someone is coming in and they're checking on you. And they're seeing how you're feeling. They're seeing how you're responding to contractions. As a student midwife, I've been to many, many, many births out of hospital, many in hospital as well. Out of hospital, when I was the one who was using the Doppler, I would often prioritize giving the family privacy depending on what the family needed. If the family wanted privacy, I would wait in the living room or outside of wherever they are. Then I would go into their room every 30 minutes and I would listen. And that gave me an opportunity to check in with the mom. And I would notice every 30 minutes that I would see her contractions were closer together. Her sounds were changing. I would check in with how she's feeling. Are you hydrating? Do you need a snack? Is it really uncomfortable in your back? Okay, do you want to try this thing? So I'm giving mom continuous check-ins and support. With the continuous monitoring, the continuous support throughout labor is not present. So moms are being monitored by machines and providers are looking at the data out somewhere else, monitoring mom elsewhere, and maybe monitoring many patients at the same time. So mom is not getting continuous support by a trained healthcare provider. They're getting continuous monitoring. And that's a very, very different thing. And this is why midwives and providers who offer continuous support all throughout labor improve outcomes. Midwives improve outcomes because midwives know how to support normal physiologic birth. That means a midwife is supporting you throughout labor and they can tell, maybe you're experiencing a lot of pain in your back. Maybe there's a positioning issue. What if we do an exam and see what's going on? Oh, I just found out the baby is perhaps facing forward, which is OP, occiput posterior. Okay, baby's facing forward and that's why you're having so much discomfort in your back. What if we try these positions to help encourage your baby to turn? Midwives carry traditions passed down through generations of midwives, especially traditional midwives and certified professional midwives that were trained in the apprenticeship model. And all of these tools and skills support normal physiologic birth. I'll give you a brief example. There was a mom who shared her story on my podcast. You can find her on Instagram. Her page is Whole Birth Wellness with Vic. She had a twin home birth. She was dilated to about 1 centimeter. And the day before she went into labor. When she went into labor, the next day the midwife checked her and she was still at 1 centimeter. And she felt like, I feel like something's wrong. Like, why am I not dilating? The midwife discovered that she had some scar tissue inside the vaginal canal from a previous tear. So the midwife massaged that scar tissue to relieve it, and she dilated to 9 centimeters almost immediately and pushed her babies out not long after that. So this is a really incredible example of how midwives support normal physiologic birth. With an OB, they might just say, well, you're still at 1 centimeter, nothing's changing. Looks like it's failure to progress. We're going to give you a C-section. So midwives are the ones that are really skilled with intermittent auscultation. You can access midwives in home births. You can access midwives for birth center births or for hospital births. And some people have more access than others. So there are states where there are not a lot of home birth midwives accessible, where home birth midwives aren't allowed to practice. There are areas that are rural areas where we can only access midwives at a hospital a couple hours away, right? So not everyone has the same kind of access, but those are the three different categories of where midwives support birth. A lot of people think that if you're at a hospital, which is maybe your preference, you can't access a midwife, but many hospitals do have midwives. So intermittent auscultation is something that is offered in some hospitals, coming back to like if it's in the hospital or not, and it's not offered in other hospitals. Every hospital should offer intermittent auscultation as an evidence-based way to support outcomes and reduce the risk for unnecessary interventions like cesarean and forceps and vacuum. There are many hospitals that do offer intermittent auscultation. However, unfortunately, there are many hospitals that do not offer intermittent auscultation, that say that continuous monitoring is mandatory because it protects their liability. Those hospitals are more interested in protecting their liability than they are at improving outcomes for the community. This is an example of defensive medicine and the way capitalism and liability has shaped modern medicine. I highly recommend that you talk to your healthcare provider and look for a hospital that offers intermittent auscultation if you are a low-risk person. And let's talk a little bit about low risk and high risk with intermittent auscultation. So unfortunately, we don't have a lot of research on continuous monitoring versus intermittent monitoring for high-risk groups. So the research we have is on low-risk groups. So what if you're in a high-risk category? Every provider has a different opinion on high risk. You're over 35, you're high risk. You have gestational diabetes, that's diet controlled, you're still high risk, right? Even having a 2-vessel cord instead of a 3-vessel cord, which are the vessels that are inside the baby's cord. Now, are you high risk? One provider might say you're high risk, another provider might say you're not high risk. In the midwifery model of care, many midwives do not believe that simply being over 35 or having diet-controlled gestational diabetes, or even potentially a 2-vessel cord, is a high-risk thing, and that would require someone to be in hospital getting continuous monitoring. So unfortunately, because we don't have data to say exactly if you have this thing, it means it's safe to do this and not safe to do that. It's more about really understanding the full picture. So am I in a high-risk category that would cause an increase in the likelihood for a baby to suddenly not do well during birth, or the placenta to suddenly not do well during birth? Does gestational diabetes impact those risks? Really like asking those questions and understanding like what are the risks that come with this thing or that thing. I will say for out-of-hospital midwives, many of them do support moms out of hospital and consider them to remain in a low-risk category if they have gestational diabetes that's diet controlled, if they are over the age of 35, and so on. However, if we are in a situation where maybe the baby is growth restricted and we're thinking that there's a problem with the placenta being able to give baby what they need, that might indicate that during labor, baby and placenta might not tolerate labor well, and continuous monitoring may be important, right? So it's really just about understanding. And if when you're advocating intermittent monitoring or exploring your options for monitoring, if you're in that situation, I recommend that you just convey to your provider that you want to understand why. I don't want to make choices for my birth based on an algorithm or policies. You're in this category, you get this thing, right? I want to understand. Can you help me understand? Can you explain to me why this puts me in a category where you're telling me that continuous monitoring is important, so you can understand and make an informed choice for yourself? If we are in a situation where we're taking Pitocin in our system, where we're taking misoprostol, or other medications that can cause the uterus to contract artificially, it's important then, of course, to monitor baby continuously, because if baby isn't tolerating those medicines, it's important to know that. It's important to monitor baby and make sure that they're doing okay, because those medicines can be very dangerous when used inappropriately. and we can cause harm to babies. Providers can cause harm to babies if they're giving those medicines and not monitoring to make sure that babies are doing okay and tolerating labor okay with those medicines. So anything that increases the likelihood for fetal distress, it's a good idea to use continuous monitoring in that case. However, one thing to be aware of is that with those medicines, you can use them to start labor, but you don't have to keep using them all throughout labor. It's evidence-based to use Pitocin to get you into a good contraction pattern and to reach the desired effect, which means you're at a good contraction pattern, you're in labor. Or maybe we've sped up your labor and it's back on track. Once we're there, continuously giving someone more Pitocin and increasing the Pitocin comes with risks without a lot of benefit. So it is evidence-based to turn the Pitocin down or off. And potentially after some time that the Pitocin has left your system or you haven't been getting Pitocin, you may be able to have a conversation with your provider about switching to intermittent auscultation at that point. We don't have a lot of research on this, so this is just a conversation to have with your provider. So next step, or the next thing I want to talk about, would be the third option for monitoring. This is intermittent external fetal monitoring, or intermittent EFM. This is a little bit different than the continuous monitoring and the intermittent monitoring. It's kind of like a blend of both. And what this looks like would be you are monitored for 10 to 20 minutes every hour. So let's say you have an hour, you're going to be monitored for 10 to 20 minutes, and then for the next 40 to 50 minutes, you're off the monitors, and then you're back on the monitors, and then you're off. This can be a compromise. So the benefit of this is that we're compromising with care providers, saying like, okay, I know that you really don't want to do intermittent monitoring, but I don't want to do continuous, so maybe we'll just do continuous a little bit. And they might be okay with that. However, we don't have research to support that this is a good option. And research shows that the intermittent EFM doesn't really offer any clinical benefit over intermittent monitoring. So we haven't seen anything in research that says that this is beneficial, that this improves outcomes. It still can lead to a higher C-section risk. Another form of the compromise, let's say, like when we're choosing to do a little bit of external fetal monitoring continuously, but not throughout all of labor, would be you arrive at the hospital, they put you on the continuous monitors for an hour, and then after that, we do intermittent monitoring. Once again, this isn't really studied, and it still will come with an increased likelihood for a C-section by being continuously on the monitors. I've heard that some hospitals who offer intermittent monitoring first require that, and it's not evidence-based, but that's what they do. So okay, so we talked about the three different options for monitoring throughout labor. We talked about continuous monitoring, internal and external, wireless and wired. We talked about intermittent auscultation. We are monitored intermittently all throughout labor. And then we talked about intermittent external fetal monitoring. Yeah, I want to share a few more things to kind of summarize everything that we talked about. So the first point with continuous monitoring is that there's no improvement in major health outcomes. So large-scale reviews have found that external fetal monitoring increases the likelihood for cesarean, forceps, and vacuum without improving outcomes for babies. Cerebral palsy is not prevented by external fetal monitoring, which many people think that it could be. It makes sense if we're listening all the time, we'll catch things quicker, but that has not been shown in research. And many health organizations like ACOG, ACNM, SOGC, and NICE state that intermittent auscultation is a safe and evidence-based choice for low-risk families. So let's now talk a little bit more about advocacy and things that you can do to advocate for intermittent monitoring if that is what you want. So number one, have the conversation prenatally. I recommend that everyone have a conversation about monitoring with your providers. I do not want anyone to say, yeah, I think I want the intermittent auscultation, and just assume that they offer that and get to the hospital and they try to put the belts on you and you say, oh no, I'm choosing intermittent auscultation. Like, oh, we don't offer that here. Oh, but that's what I choose. We don't want to be having those conversations in labor. We want to have as many of these conversations as we can as possible. So speak with your healthcare provider about what they offer. Shop around. I I just want to stress to you that the best path for your birth is a space where you're getting support in the ways you want to be supported. So if you can access a hospital that has midwives, if you're planning a hospital birth that offers intermittent auscultation, that's going to be so much better than the hospital that doesn't have midwives and that offers continuous, or that only offers continuous monitoring. Because when you're in that model, you're going to have to fight more to get what you want. You don't want to fight in labor. So have a conversation with your provider. If they say continuous monitoring is absolutely necessary and I won't allow you to do intermittent, clearly they don't honor evidence-based choices. Clearly they don't honor informed consent. That's not a great person for you. So if we can find a different hospital or different provider, I recommend looking into that. Some moms think it's too late. I'm 32 weeks. I can't transfer. It's never too late. Sometimes it can be too late to transfer to an out of hospital. 35, 36 weeks is typically max cutoff when a midwife would take you for a birth center or home birth. I have seen midwives take people later on, but so there's always hope, but most of the time there is a cutoff. But hospital transfers typically can happen even, very late into pregnancy. So at any time, know that it's always worth doing everything you can to find the best place that offers intermittent auscultation as an option already. Next would be to know your rights and to know your options. So you have the legal right to make whatever choice you want to make for your birth. You have the right to say no to anything you don't want. You also have the right to request interventions that you do want. No one can tell you what to do. No one can. No one can force you to have a cesarean. No one can force you to get on continuous monitoring. Every single intervention you are legally protected from getting if you don't want. Unfortunately, we live in a culture where, since informed consent wasn't part of the foundation of the obstetric system and culture and model of care in the beginning stages, especially because at that time, throughout the early 1900s and mid 1900s, it was thought that women weren't capable of making their own decisions. So it's really part of that system that we have to control birth, that we have to make decisions for women. So informed consent isn't part of that process and isn't inherently part of that model. You might have a provider that honors informed consent, but many providers still do not. And so even though you have the legal right to make whatever choice you want, you may not be offered your choices. You may not be supported in discovering what choice is best for you, and you may not be respected in that choice. So it's important that you understand that right. If someone says, oh, but continuous monitoring is required. No, it's not. Nothing is required. Hospital policy says, okay, and, hospital policy says that, and I'm making a different choice. I recognize that it's inconvenient for me to make a different choice, for me to go against hospital policy, but this is still my choice. Thanks so much for understanding. Thanks so much for respecting my choice, right? So you have the right to make whatever choice you want and decline anything you don't want. Next would be to ask the team to explain their concerns. Let's say that you are in a situation where maybe you're getting some continuous monitoring and the OBs come in the room or the provider comes in the room and they say, I'm not super happy about what I'm seeing with baby. You could say, can you tell me what you're worried about? Because this is going into reducing your risk for C-section with continuous monitoring. Advocacy is a big part of that. So if someone says, I don't really love what I'm seeing on the monitor, you can say, well, tell me what you're worried about. I want to be part of the choice, like the decision-making process. I want to be a partner in my care. Many providers are doing things routinely because they're seeing so many people. So it's not that providers are bad people that don't care about you. It's not that you're just like a number, you're a person, but providers kind of forget to treat you like a person sometimes because they're just rushing. And so it's not due to any bad intentions. Most of the time, really, it's just like I have to see lots of different people. I have to do lots of things. I'm monitoring lots of things at once. So I just want to come in, assess what's going on, tell you my recommendation, and go on to the next person. But you're a human being that wants to be a partner in your care. So you could initiate a conversation, and often providers will be like, oh, thanks, that reminded me to like kind of have a conversation with you. They might not be thinking about that in the moment. So can you tell me what you're worried about? Can you tell me what you're seeing? Can you tell me what the risks are? Can we have a conversation about this? If a provider says something is going on with the baby's heart rate, I'm not loving it, I'm concerned, maybe you need a C-section. That can feel really scary, to not be wanting a C-section and to hear a recommendation for you to get a C-section. That can feel so scary. And if you're really scared, your nervous system might get activated and it might feel hard to advocate. So I would clarify, is this an emergency, or do we have time to talk about this? Because if this is an emergency, then I want to know so that I can make choices accordingly. But if the provider says, oh, it's not an emergency, we have time to talk about it, but we should probably figure something out soon, or like, but we need to make a decision about this, it's like, okay, we can calm down a little bit, we can take a breath. It's not like we have to rush off or make a choice in this moment. So let's just take it one moment at a time. And let's just ask some questions. Go through brain. What are the benefits? What are the risks? What are all the alternatives? What does my intuition have to say? And what about doing nothing? If it's not an emergency, you could go through that list of questions, and then you can ask the provider, could you step out of the room, give us a few minutes to talk about it? If you want to explore alternatives and the provider makes it clear that it's not an emergency, then in that case, you could choose to get in different positions. You could get in hands and knees. That can sometimes resolve a cord compression issue, which maybe is making baby's heart rate go low. What are other alternatives? Another reason why baby's heart rate might get low is because you got an epidural. Getting an epidural increases your likelihood for your blood pressure dropping by 11 times. So it's very likely that blood pressure could drop a little bit when we get an epidural. Sometimes that's not a problem. Other times that can cause baby's heart rate to drop, and that can cause a panic, and it can cause this conversation around C-section. So if that happens, maybe we need to bring mom's blood pressure back up. Hydrating mom with oral hydration and also IV fluids can help bring mom's blood pressure back up, especially if we can get electrolytes into mom's system. Another option would be medication to bring mom's blood pressure back up. Maybe that was the problem, and maybe we can fix that problem, and that will help baby's heart rate improve. So that is another option to consider if we're trying to figure out, why is baby's heart rate going down? Is it a position cord compression thing? Is it because my blood pressure dropped? Is it because I'm dehydrated and I need to be hydrated? IV fluids routinely, aren't necessary for everybody throughout labor, but they can be very helpful on a case-by-case basis, and this is one of those situations. Another alternative would be something called an amnio infusion. An amnio infusion is when the provider takes a tube and places it inside the uterus and then flushes saline or pumps saline into the uterus. This water, the saline around the baby's head, basically creates a cushion as baby's coming down against the hard pelvis. A cushion of water around baby's head can sometimes help the heart rate improve. So maybe that is something that we can explore. Maybe you're wanting a low intervention birth and don't really want a tube coming out of your vagina. But if we're in a situation where baby's heart rate is concerning and we're considering a C-section, maybe using that amnio infusion is the right choice. If you forget what an amnio infusion is, you can always say, what's that tube that puts water in my uterus? And they'll know what we're talking about. On my free birth plan template, which is inside my Peaceful Birth Academy, in Module 2 of the Peaceful Birth Essentials course, my birth plan template is there. And I indicated on there, if a non-urgent heart tone concern arises, I prefer to try position changes or the amnio infusion. So I indicated that, and I think it's good to indicate what your alternatives are, because if you are in a place where something is recommended and you learned about alternatives but you're forgetting, you just have that there already. And in my coaching program, you'll learn all about the risks, benefits, and alternatives to all the different options available, but that is one that I make for free. There's one more reason why baby's heart rate might drop suddenly that I want you to be aware of, and that is called the dive reflex. So the dive reflex means that baby descends quickly. This might happen, it could happen with any baby, but it especially is more likely to happen with someone having their third or fourth baby, where a baby might just come through a little faster. I did see this, it was someone's fifth or sixth baby actually at a home birth, and baby was doing well all throughout labor, going through the pelvis, did their turn, was coming down, mom was pushing, and then all of a sudden the heart rate, we listened to the heart rate, and the heart rate just dropped. And we all looked at each other and we were like, call 911. So we called 911, and then the midwife realized I should just check and see if the baby's right there, because sometimes the baby's heart rate will drop as the baby goes whoop, and they just like come down really quickly to the perineum. So we checked and baby was right there at the perineum. So if you are noticing the baby's heart rate is dropping and we're concerned, maybe getting an exam and seeing what's going on might be helpful, because if you're feeling a lot of pressure, or if you were pushing, or if you have an epidural and suddenly you're feeling a lot of pressure, maybe that means that the heart rate dropped because the baby's just about to be born. When the baby's just about to be born, they get squeezed. This can cause a vasovagal response. Sometimes it can cause a little cord compression, and then baby comes out. That's normal. Baby shouldn't hang out at that place for a long time, but this is something that can happen. So an example of a number of baby's heart rate would be, what I have seen is 80, like baby's heart rate was like in the 130s, and then baby went really deep into the vaginal canal quickly and just went to the perineum so fast. And then baby's heart rate went down to like 80. And everyone freaks out, and then we check and baby's actually right there and they're about to be born, and that's why the heart rate went down a little bit. So I'm not saying that 80 beats per minute is normal, because it's not. Anything below 110 is considered to be too low. And in that normal variability of baby's heart rate, sometimes that can happen right before baby is born sometimes. So next thing I want to talk about would be with advocacy, to speak their language. So I want to teach you the language of understanding baby's heart rate. So there are different categories to assess how baby's heart rate is doing. The baby's heart rate is reassuring. We're reassured by baby's heart rate. We look at it and say, oh, yep, that's reassuring. It's telling us, or it's telling providers, that baby is doing okay. That's reassuring. And then there is non-reassuring heart rate, which means we're not reassured. The thing to be aware of is that there are actually 3 different categories. The third one in the middle is not so sure. So a lot happens in this middle area, in the shade of gray. So when it comes to advocacy, I want you to feel prepared to advocate and have conversations and be collaborative in your care if you're doing continuous monitoring and a false positive comes up. The only thing is that we don't know if it's a false positive or a true positive, which is why it's important to clarify if this is an emergency, to change positions, to explore alternatives, to have a conversation, and to continue to be part of the conversation to see how things change over time, so you can feel empowered and confident in your choices, so your partner in your care. Even if we get a cesarean, if we end up deciding that's the right thing, if you're a partner in your care, you're making choices, exploring alternatives, you'll feel like we did all the right things and I was part of the decision-making process, rather than feeling scared and like, we have to take you now, and you're like, what's going on? That can feel much more scary. So one thing you could say to a provider about the heart rate, if they express any heart rate concerns, is, are you not reassured, or are you just not sure? Are you really concerned? Is this an emergency? Or are you just not sure? Is this a shade of gray, right? And explain that you understand that risk for increasing the likelihood for C-section to come up with the provider. Explain that and kind of go over the possibilities and the alternatives. But using that language is really helpful. Are you not reassured? Or are you just not sure? What category are we in? Because that will kind of help you understand how to move forward and give you information. I invite you with your advocacy to lead with kindness, to be open-hearted, to be vulnerable, to be curious, to be a partner in your care. So your providers are part of your team. We're not fighting against them. We're not like trying to just avoid them at all costs. We're not being mean to them. We're being honest and vulnerable. I want to do everything I can to reduce my risk for a cesarean, and it would really mean a lot to me if I could access tools that reduce that risk, like intermittent monitoring. Will you support me in that? Thanks so much for giving me that information. That was really helpful. Okay, I'm going to think about it and then we'll let you know. Thanks so much for taking care of us, right? This teamwork, right, approach is so much better for everyone involved, because providers sometimes can just kind of be quick about doing things. And if you're open and curious and asking questions, then they'll feel like they're part of your care and they'll want to help give you answers, and be collaborative together if you're inviting them to be part of that dynamic with you. And obviously there are providers that are abusive people. Obstetric abuse is a real thing and that can happen. And so if we're in a situation where we have a provider, maybe you're in an OB rotation and this is a new person, you don't know them and really don't feel safe with them, before going into birth, you can look and see if that hospital has a hospital bill of rights. And if the hospital patient bill of rights, if it's indicated there there that you can request a new provider during birth. Because if you have that right and you know that right, then there you go. We can request a new provider. We're going to exercise our right to request a new provider to protect you from experiencing or just having a negative experience with that provider. The last, actually, I'll tell you 2 more tools. One more tool would be perhaps a provider says you need to have continuous monitoring. And you could say, am I in a high risk category? And if they say, no, you're in a low risk category, but it doesn't matter, everyone needs continuous monitoring, you could say that you're open to revisiting it later. I think that's a really great approach for advocacy. So you could say, maybe you could ask a question like, okay, what are the risks and benefits? Just like kind of have a conversation. And after they explain it to you, you can say, okay, thanks for the information. I'm still going to choose intermittent monitoring for now. I decline continuous monitoring, but I'm open to revisiting it later. Maybe we can check in later. That kind of tables it and makes it seem like you're not rejecting what it is that they want you to do, but you just want to focus on what it is that you want for now, and you're open to looking at that later. The last one would be to bring a designated support person. So have a partner, have a doula, and make sure these people are well educated on advocacy. And educate yourself on advocacy. I just talked a lot about advocacy, and the advocacy information I gave you is very generalized. In my coaching program, especially in the one-on-one package, I create a personalized, customized advocacy plan for everyone, and I take you through a provider audit. So I give you all the specific questions to ask your provider to get clear on where the evidence practice gap is on monitoring, on episiotomy, on C-section, on big baby bias. We want to know this stuff beforehand. Induction. And then we can create a plan where we incorporate evidence-based strategies to reduce your risks for those specific interventions with that provider. It's very personalized. And this is why my students have outcomes 9 times better than the national average, because we don't just learn about advocacy and take an online class and learn about stuff, read books, and then hope for the best. Even getting a doula is helpful, but if we're not well educated ourselves in a way that's really deliberate around that space, what's happening is we're entering the space hoping for the best, hoping things don't come up. We want to know what's going to come up. We want to have a plan around how we're going to respond to what's going to come up, because you can learn about advocacy. But if you're in the moment of birth and someone says something and you're in the presence of a care provider who's presenting themselves as an authority figure, and you feel like, okay, I have to advocate, or a partner has to advocate and say these things and ask these questions, but I'm exhausted, I didn't eat dinner, I've been up all night in labor or supporting someone in labor, and I'm about to have a baby, our nervous system is activated, our thinking brain is off, we're in a different physiology, we're in an altered state of consciousness, we're in a different situation. And so in that environment, can we still advocate? Can we retain everything that we've learned from these online classes and books and yada yada? Probably not. If we have a customized plan that we've practiced and really integrated that information, then the information lives in your body, then the preparation lives in your body, and then we can plan out how we're going to respond to different things, and we're solid and confident on that. And that is a huge part of preparing to birth in the medical model of care, learning how to navigate that system. So before we end, I'm going to drop my link. This is a link to book a free birth breakthrough session with me. And so you can click that link. You can also, if you're on Instagram, you can go to the link in my bio. And on that call, I'll clarify the steps needed for you to feel confident and prepared for birth, and explore how I can support you in my coaching program. That is it. Thank you so much for being a part of our live training today on continuous monitoring. It was great to have you, and have a beautiful rest of your day.